sometimes through difficult decisions like maybe de-escalation of care. So let's explore this with ma'am. Ma'am, over to you.
Very good evening to all of you. And the winter has started to set in the Northeast, and it's becoming very pleasant in the evenings actually. So I just cut short with my duties today, and I had taken a very lazy afternoon. So I slept through the afternoon today, and I'm quite charged up to take this session. As Deepak has already told, it has to be a very interactive session, because you as doctors, we always face ethics related problems in our day-to-day activities, day-to-day practice. So we may, many a time agree to disagree on many points, and sometimes it might happen that you'll be bound to think, why is it like this and why is it not like that? So, I may not be able to give you the correct answers, but we will all together try to, find out or come to a conclusion which will actually satiate our curiosities. So, not going into much of my talking, I would like to share my screen and start right away. So, is it visible, my screen?
Yes, ma'am. If you could just come on full screen as well.
Yes, yes. Is that right? Is that all right?
Yes, ma'am. Perfect.
Excellent. So, today we will, touch upon some little definitions, and the most importantly, we'll touch upon the 4 cardinal principles of medical ethics, and the hot topic of euthanasia, which is so very important, because it there is a slippery slope which actually really gets everything on us, and it becomes difficult for all of us to understand what exactly euthanasia is, and how we tackle situations where people actually give us Google search many things and then come and give us a lot many facts about euthanasia. So what is moral code of behavior? Our ethics is actually dependent on some codes of behavior that we generally make for ourselves, and similarly, it is also applicable for the medical practice in question. So ethical principles are basically a set of principles which should function as an analytical framework that expresses the general values underlying the common morality of people. So our work, our day-to-day practice are generally defined and governed, so to say, by such principles, and they are actually to save us from doing wrong towards our patient and justifying our actions at the same time. Generally, the ethics of palliative care are essentially of those of medicine in general. And we must know that we as doctors have a dual responsibility. The first responsibility is, of course, to preserve life. But the second one, which is more important, is to relieve suffering. So, having said this, we have to understand, we have to, realize the fact that at the end of life, the relief of suffering becomes more important, as the preservation of life becomes increasingly impossible. This is because of the fact that we are not gods, and we cannot save anybody from death, because death is the only truth in life, and death is the most inevitable thing in life. Now, the 4 cardinal principles as applied in palliative care practice are, you all know about it. It's autonomy, beneficence, non-maleficence, and justice. Autonomy is what the patient wants, and does the patient understand, does the family actually understand the patient's preferences? Beneficence is, will our action be beneficial for the patient? Non-maleficence is, will it harm the patient? Are our actions going to harm the patient? And justice is the fair utilization of resources that are available to deliver our care for our patients. Now, why do we generally talk about ethics? Why do we want to understand medical ethics? This is because of the fact that, we as caregivers, we as professionals and doctors, we are often faced with certain problems, certain difficult situations where we do not know where to go, one part of our heart or mind guides us to take one kind of a decision, and at the same time the other part of our mind and heart tells us exactly the opposite one. And then we try to find out, just like you find references to the context of a research, your mind and your heart tries to find out the context which is available for such a problem, and this particular situation is termed as a ethical dilemma. So whenever we are in a dilemma while taking a decision regarding the patient, we are faced with certain kind of dilemmas which are ethical dilemmas, and it becomes extremely necessary for us to give ourselves this justification about our actions, and that is actually going on to give a justification to our colleagues, to the patient, to the family members, and maybe the rest of the people who are indirectly or directly related to the patient care. So ethical dilemma is normally a conflict of moral principles occurring when a person faces certain situations where adhering to one particular principle might result in the violation of the other. So, that really happens actually, and it's very, very common in our practice. So let us take some examples, and from now on, I would request all of you to, give your suggestions, and maybe in the chat box, or you can also unmute and talk if that is okay, Shri Priya. So.
Yes, ma'am.
Yeah, okay. So this is a patient, and he has a jaw tumor with an orocutaneous fistula perhaps because of cheek cancer of the cheek. And then he's very much in pain. He's an elderly patient. Your reports actually tell you that there is no distant metastasis, and the patient could be treated further. Now, for the treatment to ensue, you will need to insert a nasogastric tube. The patient refuses for the nasogastric tube. So what is our stand? How do we go about this particular patient? Doesn't want the nasogastric tube. You know that the nasogastric tube is going to help in further treating the jaw tumor. The patient is in pain. So if you could give me some responses.
I think with good counseling to the patient, we can definitely convince the patient to insert rights tube. Here,
Okay.
I think that would be possible because there are no metastases. We can go ahead with the treatment, further treatment, if the patient is convinced. The only thing, we'll have to, with patients, we'll have to counsel the patient about insertion of nasogastric tube. That's what my say.
Okay. So, so you've already counseled the patient for NG tube insertion, but the patient is actually refusing it. So how do you actually convince him? Or to say, you tried convincing the patient, but still he refuses. At one point, he seems to be convinced, but at the next moment, he changes his stand and says, no, 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 I don't want to go for it. So what would be, are we going to, okay, somebody says it's percutaneous endoscopic gastrostomy. Okay. All right. So that is a procedure which might be a little more invasive for the patient, whereas, NG tube insertion is not at all invasive. That is my stand on that. But I just want to know, apart from what the doctor has said, rightfully said, that we need to counsel. I just want to know, if we do not counsel, if the patient, in spite of counseling, in spite of you convincing him about the whole problem, what? Okay, so there is one chat which says, ask what patient is willing. Okay, so the patient doesn't want to go for it. Are we not going to give him this chance of getting treated? All right. So,
Ma'am, proper nutrition is required for chemotherapy or radiotherapy or any surgical treatment. So for this patient, NG tube is must. So proper counseling is the only thing with what we can do. And we can give him examples of other patients that nutrition is required for any type of treatment. So ma'am, proper counseling is the only thing what we can do for this patient. And NG tube is must.
absolutely. So we know that NG tube is actually going to help him. So right now the patient is refusing us. So, we have this kind of a dilemma between doing good. You want to do good to this patient. It is going to help him. It is going to improve his nutritional status. You do not really want to go for a percutaneous gastrostomy because it is more invasive. It might, lead to some other kind of major or minor infections. It is an easy process also, and it can be, later on taken out. You know everything about this, right? And you've actually told this patient about, tried convincing him. So, but the patient's autonomy is in question. The patient is refusing to do it. So how do we go about this? I'll just show you. Let us first understand at this point of time what is patient autonomy. Unless and until we don't understand patient's autonomy, it will be difficult for us to convince the patient. That is what our experience is, and that is what is something that we might miss while counseling. So absolutely, I agree with every one of you who has rightfully said that the counseling for the NG tube insertion is the only choice that we have. But we have offered this choice, the patient is still refusing. So we have to find out about the autonomy of the patient. So what is patient autonomy? It is the involvement of the patient in decision making. So whatever decision we take for the patient, we cannot actually hammer it to the patient. We have to place it in front of him. We have to find a way out where the patient is willingly taking that decision from us, So how it happens? It happens only when the patient is also involved in the decision making. So the importance of patient autonomy is, it is the right to have the dignity, privacy, and confidentiality always. It is the right to have the right kind of information. It is also the right to make the decisions, and the treatment decision must come as an informed choice of the patient. So here, what has happened is that the patient is, not giving us an informed choice. The decision is always, no, I will not go for a Ryle's tube insertion. So what is our next step? When we know about the patient's autonomy, the importance of involving the patient in decision making. So the next step would be to go for a right kind of counseling. And what we do here, autonomy for this patient would be, number one, informed refusal. It is not always, an informed decision. It can also be a refusal from the patient. But before we even document the refusal of the patient, we need to understand the understanding of the patient, whether he has rightfully actually understood the process. Have we actually from our side given him all the information that is required? And then explore the reasons. The patient is refusing to take the NG tube. Have we explored the reasons why he is refusing? There may be a reason that he doesn't have enough money. There may be a reason that the patient, is fearful that, they're going to poke this long tube inside my nose. I already have a, bad smelling ulcer here. I'm unable to eat. And these people are going to put this long tube. So this is a kind of a jargon that the patient is facing. Are we actually exploring on those lines? Have we taken out time to sit with the patient and give him that information, try to mitigate his fears, whatever is going on in his mind? So all these things will actually come out on a proper counseling session for these kind of patients. You'll be getting patients who would agree to whatever you say without asking questions. But at many point of times, you'll also, see patients or come across patients who really do not agree with what you do. They just don't turn up. You know that your intent is extremely good. You know that you are going to do the best for this patient. But there is a misunderstanding when the patient doesn't turn up. Why does this misunderstanding happen? Have we actually tried to explore these reasons? So, after all these things, checking understanding, exploring the reasons, and then counseling the patients, the patient still refuses. So the moral responsibility of us, of our doctors, is to support the patient even when we do not agree with the decision of the patient. We are not going to abandon the patient. अच्छा, आपको नहीं लेना है, आप किसी और हॉस्पिटल में जाइए, आप किसी और डॉक्टर के पास जाइए, मेरे पास आपके लिए कुछ नहीं है. No, it is not like that. We are not going to do that. Okay, we are still with the patient. We have to be with the patient. And believe me, in all these years of practice, palliative care practice that I have been through, patients have actually turned up even after 3 or 4 days. That doctor, you are right. I will go for the NG tube insertion. आपके अलावा मेरे बारे में अच्छा कोई सोच ही नहीं पाएगा, you know. So I have gone through this, and I'm sure when you start doing it, and you may have actually had such experiences where, you know, you may have certain disagreements on decision making with the patient family, and later on they have actually come around you. But the most important point to take an informed refusal is to find out the understanding, explore the reasons, counsel over and over again, and still not, if the patient doesn't understand, doesn't agree to your decisions, then you have to support the patient even at that point of time. So this brings us to another, another case, and it's a 20-year-old boy with the osteosarcoma of the lower end of the femur. He has a large tumor as of now, as you can see on the right-hand side of the picture. There are multiple lung metastases. There is severe anemia. We all know in advanced stages of osteosarcoma, anemia, severe anemia is the accompaniment. And he wants an amputation now, you know, but the procedure is risky, considering his general condition. So you explain the risks to him, but he still wants to go with the amputation. So I want certain your responses, your decisions, or your things on this particular case also. Yes, any responses?
If this amputation is going to harm the patient,
Yeah.
I think we should refrain from taking the decision, though we respect the autonomy of taking the decision by the patient. But if it is going to harm him, we should refrain from taking that decision in this case.
Exactly. So what do we do? So here the dilemma is between doing good or beneficence and avoiding the harm, isn't it? We are also faced with the autonomy of the patient, because the patient wants the operation to be done. At the same time, we know that it is not going to do any good to the patient. It is actually going to do harm. So it is a dilemma between doing good and avoiding the harm at the same time. Okay. So what do we do here? We need to ask certain questions to ourselves. Okay. What are his chances of cure after doing an amputation? Secondly, is the survival of the patient after this kind of a huge major operation likely? Do you actually feel, or do you foresee that the patient is going to die on the table itself? So if the survival is there at all, you know, even for 24 hours or so, will the amputation improve his condition? So what is, the point here is that we need to understand the dilemma between doing good and harming. So when we know that the thin line that separates both of these situations, we can handle it. And then we can actually explain to this patient about the three questions that I had just shown. Okay, right. So let us consider this third dilemma. So he's again a 20-year-old boy with advanced cancer. He's under your care. Now the relatives have insisted that the issues of diagnosis and prognosis should not be discussed with this boy. So when you go to see him one day in your rounds, the relatives are not there. He is alone. And he takes this chance of asking you what is wrong with him. So what will you tell him now?
Good evening, ma'am.
Yeah.
I think the first instance when the relatives ask you to not tell him about the diagnosis and prognosis, at that point itself, we need to counsel them and explain to them that it's best for the child to know about his diagnosis, because he may have certain ideas, he may have certain wishes, and which he needs to fulfill. And secondly, of course, when he's alone is not the best time to break the news to him, because he needs someone to support him, someone he knows, someone he can fall on emotionally to support him while he receives the news. So we'll have to, create an environment wherein we can break the news to him in the best possible way.
Okay. Thank you so much. Thank you so much. Any other comment? So, okay. So we have, yes, it's the patient's right to know what's going on with him. He's living his life after bad news. Like, how much does he want to know about his condition? We need to address it. Okay. Communicate with the patient regarding his disease and his progression. It's a patient's right. Okay. Terminally ill patient has their own bucket list. Okay. Very good. So this is, a dilemma where, we are trying to deliberately mislead that person by withholding some information, okay, at the insistence of the patient's relatives. Unfortunately, even when you try to counsel the relatives of these such kind of patients, they will never, agree to what you say. They will say, "Nee, doctor saab, unko to heart attack ho jayega." Okay. How many of you actually have gone through this particular thing, thanks to Bollywood, because they've actually shown that you have broken the bad news and there is a heart attack and the patient actually dies on the table. It's unfortunately, it's not like that. For our patients, I would like to assume that this patient, this young boy, has already understood what is going on, in spite of so many medications being given, in spite of the number of hospitalizations, in spite of the number of chemotherapy or radiotherapy or whatever has taken place, he's not getting better, So I would consider a 20-year-old boy to be an adult. And as rightfully somebody said, that he needs to know about his diagnosis. But having said this, don't we consider our children as children? My son is a 19-year-old, and I still believe, or, I still think that he's just 5 years, asking little things from me, going in and around somewhere, I trying to take control over his life. Don't go there, don't go do this. This is a kind of a protective mechanism that a parent has for the child. And we as parents would always want to, at one kind of a subconscious level, we would consider our children, however old they are, to be children only. And that is a protective mechanism, because we do not want our, children to get hurt. This is the same situation that these relatives are actually going on. So as, we need to counsel. That is the, right thing to do. But then, the counseling has to be slow and steady. We have to perhaps tell these relatives regarding what the patients might be thinking. They may not be actually imagining that their patient already, have imagined this disease to be at an incurable stage, So it is very important for us to understand why the patient's relatives are actually insisting us not to tell. It is similar to the first case that we have. We have to find out the reasons from both the sides. And regarding the second part, where the patient is alone and he's asking that question, perhaps the patient is perhaps taking that chance because he knows that when there are parents standing at that beside his bed, there would be some other people who are elders. He will not be in a position and not feel free to ask the doctor about that. I would generally manage that situation by telling him that it's not a good news. I would actually give him a little piece of information, not the whole of it, definitely. And then I would promise him that, let us talk to your parents also. Many times I have actually faced this situation, and I found out that they would say, no, ma'am, not in front of my parents, because the patient is also very protective about his relatives being hurt. Perhaps he's also maintaining that particular sense that if they come to know that I've come to know about my situation, that I'm not going to live more, they will perhaps land up in a situation where they will not be able to, my mother would actually keep on crying. She will not smile at me. So all these things are actually protective mechanisms of the patient and the patient's parents or their relatives, So we have to handle these situations extremely, extremely sensitively. And if you ask me my experiences of handling such situations, they would need, multiple interactions with the patient alone, multiple interaction with the patient's relatives, and at the same time, trying to bring them together in one platform where there are no screens present, so that they understand what the patient is going through, what the patient wants. And at the same time, the patient is also not fearful that after knowing his diagnosis, the parents would be hurt. So, the dilemma of trying to withhold the information, which is rightful for the patient, and at the point where the patient is actually asking for it, it is a dilemma where we need to understand the situation, the dynamics that is going on with the patient's relatives inside the family because of this particular diagnosis. Okay. Right. So another dilemma, it's a different case. So this is a 50-year-old lady with carcinoma of the stomach, and she's come to the hospital in a terminal state. And you assume that it is perhaps due to internal bleeding. So her systolic BP is 50 millimeter of mercury, and she's extremely, extremely restless. So will you give her parenteral midazolam, which may hasten the death of this patient? Okay, Dr. Madhumita says never. Okay, there's another no. Okay.
No.
So it's a big no from everybody.
No, but if we, yeah, ma'am. If the carcinoma of stomach is with metastasis, and in that case, we'll have to take this case as an end of life management. And in that case, we'll have to consider in sense of reducing her suffering. and we may give midazolam in that case.
Yes. So, as far as our medical knowledge is concerned, I think a terminal state of a 50-year-old lady with CA stomach, culminating in internal bleeding, where she's extremely restless, we would perhaps try to understand that the CA stomach is terminal. Okay, CA stomach is advanced in that case, but definitely at that point of time, when you are faced with a situation, you'll definitely have your the reports of that patient, and I'm sure that your diagnosis or your decision would be supported by other reports that are available with the patient, perhaps a PET or an MRI, or other reports that are that goes towards the diagnosis of advancement of the cancer. Having said this, yes, there's somebody who's actually said that to reduce the restlessness of the patient, it is important that we give parenteral midazolam. Now, when you do your sessions on end of life care, perhaps yes, on delirium and other terminal delirium and other sessions that are due, you'll definitely come to know and appreciate that midazolam, parenteral midazolam, is the gold standard of terminal restlessness. When the patient here is in a terminal state, at the end of life, in restlessness, we would actually consider giving her midazolam. Now, let us see why this happens. The question that must be actually going on in your minds is it right to give some medication to a terminally ill person which may inadvertently hasten the person's death? So this brings us to something very important, which is called the principle of double effect. In medical practice, and particularly very relevant in palliative care, the principle of double effect is a single act of having two possible foreseen effects, one good and one harmful. And it is not always morally prohibited if the harmful effect is not intended. Now, the intent of giving parenteral midazolam to this particular patient is to relieve her of the terminal restlessness that this patient is going through. But at the same time, we also foresee that because of midazolam, the patient might also die. Now, we have to understand that the intent, our intent, is always good. We know that the patient is perhaps in the dying phase and it is going to die. Okay? But we do not want her to die in a very restless condition where we restrain her hands, we restrain her legs, she blabbers something with her mouth. It is something, a situation where you will never you'll never be comfortable with. And it brings a lot of, different kind of a feeling for the people who belongs to the family, and at the same time for those who are taking care. There will be young nurses surrounding such patients. You'll be asking them to do something in the casualty or in your palliative care ward. And this kind of a situation, instills certain such difficult prints in your mind that it doesn't really easily go off. Palliative care people, sometimes they remember such ghastly things that happen in a ICU. So your intent is here to take care of the restlessness because the patient is suffering because of the restlessness. Okay, your intent is not to kill the person. You know that by giving midazolam, the restlessness will be reduced. But you also know that perhaps it is not always so. Perhaps midazolam might hasten the death of the patient also. Let me give you another example. We always use, morphine tablets for taking care of the pain. Now, morphine has, comes with certain benefits. Morphine comes with two important side effects also, and that is constipation and vomiting. Now, you know that if you do not prescribe morphine because of the fear of inducing constipation and nausea for this patient, you are actually depriving the patient of getting a complete pain relief. Now, if we do not do that, we are actually doing harm. And if we do that, and by knowing that constipation and nausea will be a common accompaniment with the morphine tablets, then we are not intending to give the patient constipation and nausea. Our intention is to give complete pain relief. Okay, so this is the principle of double effect. Let me give you another different example than this. So, we are diabetics are on anti-diabetic tablets. Okay, anti-diabetic tablets have different side effects also, but we want to take care of the diabetes. We do not want to, our intention is not to induce side effects through anti-diabetic tablets. Our intention is to control the blood sugar of this patient. Okay, so the principle of double effect will always be applicable in anything that we do. May it be giving midazolam, may it be giving morphine tablets, may it be anti-diabetics, may it be some other treatment. Okay. All right. So we come to a fourth dilemma.
Ma'am, can I ask you one question, please?
Yes, please. Yes, please. Yes.
Ma'am, in the case of a terminal patient who's come in, and we know she's in a bad state, and we know that any kind of intervention we may do may result in her demise. Some kind of grief counseling needs to be given to the relatives, because often I've noticed, especially I've worked in the ICU, and even though the patients come prepared initially that the relatives come prepared that the patient is in a bad condition, often when the result is bad, they kind of don't, the stages of grief, they first react in a very bad way. And how can we kind of alleviate that with counseling, and when should we do it? I mean,
Yeah.
I know
So,
taking care of the patient is primary, but to balance everything out.
yes, absolutely. I completely agree with you. And, at one point of time, I also worked in the ICU. So, we are in the same page. So do not worry about that. You see, for me as a physician, practicing palliative care, I have made a rule for myself. And the rule is that whatever counseling I give to my patients, how many sessions, whatever sessions, it may be around 20 sessions also. Every time the patient comes to me, I do not consider him accepting anything. I take that patient as a naive patient for everything that has happened. It is very important that we revise what we discussed last time. For example, the patient comes or the relatives comes, and we sit together, and then until and unless they start that. Doctor, last time we perhaps discussed, you told me about this. Until and unless they start the conversation like that, if I see that I have to start the conversation, I start it from scratch. So that is a rule that I've made for myself, because I know that accepting a diagnosis is so difficult. Let me give you my example. So both my parents are actually cancer patients. My mother is a survivor from breast cancer, but last year my father was diagnosed with prostate cancer, metastatic prostate cancer. Both of them are now, stable, without any symptoms. But there's a thing that goes on in my mind. What next? What next? Okay. And in the middle of this year, in the month of May, my brother, who's just 40 years, has 2 children. The younger one, being just 7 months, was diagnosed with a first stage of an extranodal NHL in the stomach. So that actually caught me absolutely off guard, because of the fact that I was unable to accept. He stays in Bombay, and for all his chemotherapies, I was traveling to Bombay to be with him. And the oncologist who was treating him, knowing that I'm into palliative care, cancer palliative care, basically, had given me all kind of information. There was a team who always sat with me, tried to, counsel me. But I have gone through this whole thing myself and understood that whatever somebody says, until and unless you see your patient in a normal condition, coming out of the ICU, walking around, doing the normal activities, there is no acceptance. This is my insight about it. And that is why, it is not because, I have had this experience myself, but it was a rule that I have always followed, because I wanted to mitigate the mental suffering of people. And, I've like this time I experienced it myself. And that's the proof that, people, however, whatever counseling you give, whatever kind of support, mental support you give, however qualified counselor or a team may be, please consider that they have not accepted your words. Then only, you'll be able to always, give the best from your side. Because sometimes it also happens that you assume yourself that, oh, yesterday or in the last session, so we have already had this discussion, so I'm sure the patient has, or the relatives have understood. No, do not do that. Take the best possible time, create the same kind of environment that you had in the first session, give them the warmth that is needed. Call on one of your best nurses who can share your expertise with the patient. So for your question, I would actually definitely tell you to start everything from scratch every time you meet, because that you have the prognosis of the patient. Perhaps you also have a timeline for the patient कि आज ऐसा है तो कल शायद इससे ज़्यादा बुरा होगा. So you know about this. Why not share this particular knowledge with the relatives? So that would actually mitigate many things, make things easier for you. And this I'm saying because I have gone through it. Thankfully, my brother is quite well now. And, the experience that I've got perhaps was a kind of a lesson that I had to learn in life, So I'm sure, you will also, through your patience and your situations that you go through, will definitely learn to make your the patient and the family members that you get in your setups to settle down. And regarding the grief that they go through, it's very difficult to say, because every person is different. Every individual is a different individual. The kind of acceptance they have would be very different. I have come across many people who, who tell me, we knew that this has to happen, so doctor, you have done your best. And I've also come across many people who actually blame me for every single thing. You have given this injection. Was it really needed? You had also tried out this steroid. Was that also needed? I had Googled and I found out that the steroids would do these side effects. Maybe he has gone through these side effects and that's why he's dead. So you have to be wary of these kind of questions. You have to be prepared for these kind of questions, and believe me, it's going to make you a stronger person. And as experiences come by, you will definitely find your own rules and strategies to mitigate all this. Does that answer your question? I don't know.
Yes, ma'am. Thank you so much.
Okay. So this is another ethical dilemma. And so this is a 74-year-old gentleman with advanced carcinoma of lung who had completed a course of radiotherapy and 2 courses of chemotherapy. He's brought to the casualty. He's drowsy, his pulse is feeble. So systolic BP is 60, his breathing pattern is altered. Now the family wants everything possible done for this particular patient. So what do we do in such kind of a situation? Do we resuscitate and shift him to the ICU? Remember, he is a 70-year-old gentleman. He has an advanced carcinoma of lung. And whatever findings we have in this case, the patient is perhaps in the last few hours of life. So what do we generally do? In a normal hospital, we actually put the patient into a ICU. So I want to ask you one question, that is this very, very important? Do we actually consider the hydration, nutrition? Do we consider a ventilatory support? Do we really have to go through this? So the point is, what is an appropriate treatment? We need to ask ourselves, are we appropriately treating the person? If we have a patient of malaria, are we treating appropriately? If we have a patient of dengue, are we giving an appropriate treatment, or are we over treating? Or is it, the question is it a to the point treatment? Now, for these kind of patients, the treatment that does not provide net benefit to the patient may ethically and legally be withdrawn, and the goal of medicine should shift from curation to the palliation of symptoms. And when we talk about palliation of symptoms, we have to understand withdrawing of treatment options also. Okay, for a 74-year-old gentleman with a advanced cancer of the lungs, where the patient is showing the signs of impending death, we should not be putting him in an ICU. Okay, and that is ethically wrong if we actually get this person to the ICU and do all kind of unnecessary investigations. Okay, so our focus needs to be on what appropriate treatment for such patient needs. Okay, and henceforth the key points that we need to remember when we devise our appropriate treatment for patients, whatever stage the patient is in, We need to see for the patient's biological aspects or prospects, the therapeutic aim and benefits of each treatment that we advise for the patient, the adverse effects of each such treatment, and the need of not prescribing a lingering death. Because if we put this gentleman in the ventilator, his death will be obviously lingered. Okay, so think about the appropriate treatment options, the key points that you need to remember when you deal with such kind of people. And I would reiterate the fact that you need to have a lot of a robust kind of a knowledge, scientific knowledge, basis which you will be able to justify your actions of not putting the patient through a ventilator. Okay. So that brings us to the principle of justice, and that is balancing the needs of the individual with that of the society. So let us just look at this particular patient and think about the principle of justice. Okay, I'm sure you know about this particular principle, but let's just go through it. So this person is 86 years old. He was a journalist. He was once upon a time a war correspondent, and then he landed up in cancer of the lung, with metastasis to the spine, ribs, sacrum, and every possible place. So he has a son who has a psychiatric disorder, and there are 6 grandchildren of this person. Okay. Now the goals of care for this particular patient would be, for palliative care, would be taking care of the pain because of the numerous bony metastases that the patient has, looking at the family finances, because one of the son is a psychiatric patient. He needs proper psychiatric treatment all the time, where some of the finances are actually going towards the treatment of the son. At the same time, he has 6 grandchildren to look after. Okay. And then he wants to do some kind of a Janevu Sanskar for his 3 grandsons. So all these things are kind of, mixing up with the treatment. Now, we also see that the breathlessness of this patient is actually increasing day by day because of the primary cancer. So do we need to do an ICU admission here? And if we do want to do an ICU admission, will it be a fair utilization of the resources? Will it be a fair utilization of the hospital resources, the family's resources, and the society's or the nation's resources? For example, we have a head injury patient, okay, just outside the hospital. He comes to the casualty and the no ICU bed is available. Are you not actually, depriving this young patient who could be revived by an ICU admission? So all these things comes into the principle of justice. So we are anyway a very poor country. I would consider India definitely a poor country as of now, because we are in the metros, but there's a lot of poverty outside. There's a lot of poverty outside the urban areas also. People really do not get proper health care, even the primary health care also. So where India being such a poor country, and then with very limited resources of healthcare, are we actually fairly utilizing that for everybody who's there? Because healthcare is a right for everyone. It's an equal right for everybody. It is not only that the rich will get everything and the poor doesn't. Okay, so that is about the principle of justice, and that brings us to something which we are, all the time perhaps discussing being in palliative care or being in cancer care, we are discussing about euthanasia. So it is an act or procedure in which someone takes active means, such as a lethal injection, to bring about someone's death. Okay. So you should actually give your stress to the points called active. Euthanasia is always active. There is nothing like passive euthanasia. I'll discuss it in my later slides, but keep it in mind that euthanasia has to be active, because our intention is bringing about the death of of this person by giving an lethal injection. Okay, we are not like sitting back and trying to see that the patient is dying or will be dying. Okay, at the same time, when we allow natural deaths to happen, and that may be by withholding or withdrawing a futile treatment, will not amount to euthanasia. So please take this particular message today, that euthanasia is not allowing natural death to take place. And when we withhold a treatment process, and we are withholding ventilation for somebody like that 74-year-old gentleman who was with the last stage of cancer, we are withholding hydration, we are withholding nutrition, and all these things, all these supports. It doesn't mean that we are euthanizing him. We are allowing the natural process of death to happen for that particular patient. Okay. So, you see, there is a legal provision for this particular thing in IPC section 88. Okay. It's a huge thing. You can actually go to the IPC section 88 and read about it. It's a huge chapter. Okay. But unfortunately, we have it in India. We have not actually practically applied this in our situations. Okay, so it does give us a small overview of withholding treatment or withdrawing treatment, and the difference between euthanasia also. But we haven't been able to apply it practically in our situations. So why do we have to know about futile care here? Because we are in a situation where we want to do everything to save the patient. That is the mindset. We became doctors because we were told that you are the chosen ones to save people. Okay, but we need to understand the term called futile care, and we also need to understand that we are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting our patients. Okay, so we do not have this ethical obligation that we will deliver a kind of care which must benefit our patients. We are not ethically obligated to do that. And this is particularly written in the AMA Code of Medical Ethics. Okay, so please be wary of these situations. Please do not go on giving a futile kind of a treatment for your patient. That is actually going to make the patient suffer more than actually benefiting the patient. Okay, so having said this, why do doctors go for futile treatment at all? We see nursing homes bigger hospitals, corporate hospitals, doing this day in and day out. Why does this happen? This is because physicians are not oriented to physicians are always oriented to curative treatment only. Okay. They have no training in palliative care. Once you undergo proper palliative care training, the acceptance of failure to, not to fight death will easily set in. I have a lot of oncologist friends who actually refer their patients to me for pain management, but I've also seen them, fighting death at the end of it also. And then, going into some kind of depression there, oh my God, I couldn't save this patient. So those people do not have a training in palliative care. They are always wanting to cure their patients. Okay. At the same time, there is a fear of being blamed for suboptimal treatment of their patients. You have not treated my patient well. That is why he died. So that's very common. That it really comes to you. Okay, so you don't want to hear all these things. That's a fear that we get. And then the ignorance about the guidelines for end of life. There are certain guidelines that have been set for end of life care. And I'm going to give you a link for that in my next slide. And then, if we do not do anything for the patient, the question of euthanasia comes. People actually will tell you, okay, oh, you have actually withdrawn the patient from the ventilator. That means you are killing the patient. So you're not going to do anything for this patient. That means you are killing the patient. Now, there is an end of life care policy, and it has been given jointly by the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care. Please go through this. Please go through this. It gives us a 12-step plan to get the, to do a proper end of life care. And it's a huge policy. You should actually look into this paper. It's a very important guideline for those who are practicing in ICU setups, for those who are practicing in palliative care. It's very important for you guys to know about the end of life care policy. And it is there in the Indian Journal of Palliative Care. Please go through it. So, while talking about killing and letting die, there is a logical distinction at times that becomes very, very problematic, distinction between the killing and letting die. So there is a moral prohibition for killing. We all know that. But people at one point of time will invariably die. Okay. So it is a fact that sometimes dying patients are given futile treatment also, which will actually compound their suffering. And so there is a need for letting the patient die at that point of time. Okay. So this will necessitate the withdrawing or withholding of treatment. Right. So with the advent of a lot of modern techniques and technology, so the distinction between the killing and letting die has started to appear very blurred in many situations. Okay. Having said this, prolonging the life of a patient is very good. But, when we prolong the dying process, that cannot be considered good. Okay. So we have to know the difference between killing and letting the person die. Killing is something which is active, and letting the patient die or letting the patient go through the normal dying process is not bad. Okay, it is letting the thing happen very natural. So again, coming to the question of euthanasia, if you are still troubled with this question, it has to be a deliberate intervention, right? And this deliberate intervention is undertaken with the expressed intention of ending life to relieve intractable suffering. Okay, please do not get confused with the last thing, like ending life to relieve intractable suffering. You are seeing the patient, that the patient is suffering a lot because of pain, because of restlessness, because of breathlessness, and then you give that patient a lethal injection to end his suffering. So you are actually killing the patient. You are not allowing the natural process to happen. So what ideally should be done is relieve the intractable suffering of the patient by complete symptom management, complete pain management, complete management of terminal breathlessness, which is absolutely possible. Okay, there are many things, many medications, many interventions that we can do to end the suffering of dying patients. But causing the patient death is not an option for us. So when we cause death to relieve intractable suffering, that amounts to euthanasia. And hence, euthanasia is an active process. Okay, it cannot be a passive process. It is intentional killing of our patients. So you must be knowing about do not resuscitate, and you learn a lot about do not resuscitate when you attend your sessions on end of life care in your fellowship course. So now, having said this, I want to ask this particular question to all of you. So using morphine and other drugs to relieve pain, does it amounts to euthanasia? No. Stopping the treatment when the burden outweighs the benefit, does that amounts to euthanasia? Not at all. And then allowing nature to take its course, does that amounts to euthanasia? Not at all. So these are three situations that we as palliative care physicians or people working in the ICU are faced with all the time. And please, from now on, do not think that you're using morphine to relieve the pain of the patient and you are euthanizing. No, it's not like that. Okay, you are allowing the nature to take its course. You're not euthanizing. Okay, so please relieve that burden from your heart today. Please read this book also, Being Mortal by Atul Gawande. And it's an excellent book. I'm sure many of you till now must have read this book quite a lot of times. It gives a lovely overview of what happens to terminal patients, So please go through this book if you haven't. So we cannot afford to die in the ICU, okay, for many reasons. 85% of our healthcare spending is out of pocket. Okay. 39 million Indians are becoming poorer per year due to rising healthcare costs. And this is from the Lancet. Most related to aggressive medical interventions at the end of life. And there is a 300% increase in inpatient expenditure in the last 10 years. So, we just don't want to die in the ICU. We cannot afford actually to die in the ICU. Okay. So today's take-home message will be, apply the ethical principles against the background of the respect for life, and at the same time, acceptance of the ultimate inevitability of death. So if we apply these principles from now on, many of our ethical dilemmas will be solved. We may also, face certain situations where we feel that it has not been solved, but we can, up to some extent, get our answers and also give answers to our patients and the family members also. Okay, so I rest my presentation here, and I'm open to questions. Thank you so much for a patient hearing.
Good evening, madam. I am Dr. Bharati from Tirupati, madam. Madam, we are getting more number of ICUs. That means anesthetists are undergoing training for critical care. And if they are also being trained in the palliative care, probably they can decide when to stop the treatment and without causing much burden to the patient and also families.
I completely agree with you, ma'am. That's a very important thing that you have said, and I'm sure that you'll be able to convince them to take up a small course in palliative care, and it's immensely going to help not only the patients and the family members, but also them, to take proper care, as well as getting out of such situations, managing such situations in a proper manner.
Many times they will be afraid that the family members may curse that we have joined the patient to get cure and get discharged. But what you are telling like this, that might be the fear for them. Then should we counsel them in the beginning itself, madam?
Yes, ma'am. That is very important. Whatever patient you get in whatever stage, may it be cancer or may it be any other disease, talking to your patient and the family members is extremely important. It builds up a rapport between you and your patients. And when you build up that rapport, that the family members and the patient is in your side, in your team, so that will make many things solve, like the problems will never occur itself, so I would really appreciate if you start doing that, spending little bit of time. I don't say that you have to go out of the way and spend 1 hour, 2 hours with one single patient. That is not necessary. Giving them just 5 minutes, the important things that you jot down while talking to such patients, while giving information to such patients and their family members. Whenever you are on the rounds also, you can actually walk with the patient family members, talk to them in a very friendly manner, and your gestures and everything that you do, kind of welcome them to the world that you are in, is also makes them very, very comfortable. And, as the time goes by, you give them bit by bit of information regarding their patient, the condition of the patient, whether it is improving, whether it is, not improving, or whether the patient is actually going towards a terminality. All these things, if you try to do that, I think that's a wonderful thing to do.
Thank you, madam.
And we have a question in the chat box. There is a common perception that shifting a person to the ICU could have saved the life of the person. How to deal with such people?
Yeah, so that's a very dicey question that's been put to everybody who's actually not working in the ICU, you know. So perhaps what happens is that somebody is not working in the ICU, and all of a sudden you find a patient whose family members would say, "Aap ICU mein nahi dalenge kya? You're not going to put our patient in the ICU." So you know, this question is a kind of what to say, a boomerang, because once you say nahi dalenge, it's going to come back to you at the next moment again. Okay, and this is very important because when you are thinking about ICU care for a patient, again you have to explain why you want to put the patient in the ICU. Okay, as I said in our presentation, the appropriate treatment for a patient. Jot out the appropriate treatment for that patient and share with the family members. You have to share with. If you do not share it, if you do not, again, it's the question of autonomy. Again, it's a question of giving the right kind of information, which is rightfully due for such patients. If you do not give that information, they are going to say that you have not treated our patient in the ICU. Okay, why do people have this notion that treating the ICU patient in the ICU will have a better outcome? Because they have not been given the right information. You have to give them perhaps examples that, if we treat your patient in the ICU, these many things might happen, which we do not want to happen. Okay. And at the same time, you have to counter their, what to say, kind of a, if I may use the word, baseless fact that taking the patient to the ICU will save the life. It is not like that. You have to give them the distinction between where the life can be saved, where the life cannot be saved. Okay. And even if you save the life by putting the patient through a ventilation, you are adding up to the suffering. Tell their family members, do you want your patient to be inside the ventilator for the rest of the life? Do you not want to visit your patient as a normal person? So, if you start telling all these situational things, if you give them these comparisons, I'm sure they are not going to opt for any kind of ICU care for terminally ill patients. But of course, if there has been a major surgery, even if the patient is in a metastatic condition, for example, a hemicolectomy for colon cancer, the patient has to be in the ICU. He's going to get better in the ICU. You cannot just say, no, this patient is metastatic and he's going to die, so we not put. It's not like that. So remember the key points about appropriate treatment. Appropriate treatment at the right point of time. That is actually going to save you from getting bombarded with these kind of questions. I hope I've answered the question.
Thank you so much, ma'am. We have one more question. Probably it can be the last question which we take from the chat box. If the patient relatives have agreed for do not resuscitate and then change their mind suddenly when the patient goes to the stage of a ventilator, should we change the plan of management?
So yes, this is a very interesting question because many times this happens because, they have actually, you have had a very nice ride with the patient family because you have assumed that the patient and the patient family is along with you. And they have been saying, yes, doctor, okay, doctor, thank you, doctor. All of a sudden, no, doctor, we want our patient to be in the ICU right now. Okay. And at that point of time, perhaps you will need to explore why they are fearing for that. Whatever time you have, because you will not actually pick up the patient and put him in the ICU. You still have at least 2 or 3 hours. Okay. And at that point of time, you play your own cards. You have to tell them again, all over again. Remember the rule that they are again naive for you. They do not have that information. Think that there is a whiteboard and you have to write the story once again. So you give them the information once again that no, it cannot, it is because of these facts that we are not sending the patient to the ICU. Do you want your patient to suffer like this? And even when they do not, they don't agree with you, then perhaps you might need to give up at that point of time and then send the patient to the ICU. And at the other end, perhaps you can actually talk to your ICU friends out there working in the ICU, talk about the futility, and I'm sure they are going to understand, because they are also not expecting a terminally ill patient to be in the ventilator. You can actually tell them that okay, this is the condition, this is perhaps the last wish of the family, so let us make it happen. But try to manage the patient's family for not putting the patient into the ventilator. So there'll be a common version from your side as well as the ICU doctor's side, both of them giving the patient the same kind of version that putting the patient into the ventilator might result in these kind of things. So that will also reinforce the fact that, yes, it will be good if we do not send the patient to the ICU.
Thank you so much, ma'am. So as we all get an opportunity to lay to rest the ethical dilemmas which as a doctor we have within ourselves, many a times these difficulties arise of how do we communicate these elements to the patient as well as the relatives, the caregivers. And that is exactly what we'll be dealing with next. That is communication and its importance in palliative care and easing out these kind of situations which doctors and the beneficiaries also face. So that will be our next session, which is coming up on Monday. Before we close, Dr. Nandini, I would like to apologize on our behalf. We are aware that you had taken the effort of building a case to present today. However, because the nature of the topic today was such that we overshot time, so we'll make an opportunity for you in the near future. That's okay.
I'm really sorry about that. But if there has been, if we can discuss this, I'm absolutely free. I don't know
we
whether
have time slots, ma'am. We can take it up. Dr. Nandini, you have unmuted yourself.
Yeah, I can present. I can
Uh,
present the case.
Yeah, doctor, I think we'll just keep it for another day because we have a lot of participants. Probably they are all towards the end of their day after a long day, after long days of work. But do preserve the case so that we can take it up very near, probably in the next week itself.
Okay, okay.
Thank you so much, ma'am. So thank you so much, Dr. Sanghamitra, ma'am. I know that this is a topic on which there are symposiums and workshops which is conducted for half a day or one day. Many times these discussions go on for multiple days as well on different sessions. But you have just given us a capsule to swallow over the past one and a half hours. But I'm sure that more questions will crop up. And we can look into them as we move forward along with the course. Feel free to post your queries on your WhatsApp groups as well. We will forward them to ma'am and ma'am can probably answer them as well. So thank you so much, all of you, for your participation. Thank you so much, ma'am, for taking time out for the wonderful presentation. Shri Priya, over to you.
Thank you, Dr. Sanghamitra. Yes, as always, it has been a fascinating session and very enlightening as well. And extremely sorry, Dr. Nandini, that we could not take up your case for this session. Maybe as Dr. Deepak said, we can include it in any of the upcoming sessions. So thank you, and thank you everyone for joining. I personally apologize on behalf of the coordinator side because we had a technical glitch reported in the Zoom platform as well, and we had to come and give out a last minute message to everyone to log in. Extremely sorry about that as well. So with a promise that we will see again in the next session with yet another very interesting topic and an eminent faculty joining in. This is Sri Priya, along with Dr. Sanghamitra Bora and Dr. Deepak Sudhakaran signing off from the Tips Eco Hub. Till then, everyone, take care. Bye-bye.